Thank you again to the organizers, Sung Ho, for inviting me to this lovely conference. I've enjoyed it thoroughly. So I'm going to talk a little bit about venous reconstruction and changing the paradigm of what we think about it. Now, this is probably the lecture that has the least to do with congenital heart disease. However, there are patients that need this with congenital heart disease, but I believe that there are more patients who don't have congenital heart disease that will need this procedure. So let me just go through this a little bit. Here's the current paradigm, and I call this kicking the can down the road. All of us, whether we were in training, whether in cardiology, pediatric, whatever division or specialty we're in, we have encountered the problem where we had some vascular access issues. The patient has an IV that's blown or infiltrated, or we can't get the IV in, or the line that we put in is thrombosed, right? We've seen that happen. So what do? We basically say, we'll put another line in. If we can't get it quickly, then we call the PIC team. In the US, there's a team in the hospital that is used to put in the lines. So they come in and they'll do whatever they do to get a new line in. Once that line is in, you are happy and you go back to doing whatever you do. You forget about the vessel that was blown into place, right? That's our current paradigm. Well, when we do that, we basically dismiss the old vein, right? That's what happens. What happens when the PIC team come back and says, I cannot find a vein to put a line in? Now, of course, many times we've encountered that. So what do? You call the surgeons. They will come in and do a cut down at central access. Pretty good, right? So they get that, and then you go on to doing your work. You forget about the rest of the veins that were clotted, and you just keep going because you have a new central line. What happens when the surgeon says, I cannot put that central line in? Now, that might be rare, but it has happened because their vessels can't get into the central veins. It's blocked off somewhere. And we've seen that happen multiple times. So now, as an interventionist, this is my own first initial experience. I've seen this for over 10 years. We go to the cath lab, we poke a needle into the vein, we get blood, we run the wire up, and we cannot get the wire to go where we want to go. And we maybe, if we're thoughtful, we'll take a picture and the vein is gone. So what do? You go to the other side, right? If both sides are gone, what do? You go to the IJ. What happens if the IJs are occluded? You can get pretty creative. You can go transhepatic, and we've had multiple lectures about transhepatic access and so forth. You can get very creative, get central access to get to the heart. The other issue is that what happens if the veins are too small for the delivery of a large system? Sometimes you may need dual access. So just because you have one access, it may not be good enough for some of the interventions that we do. So at some point, the patient will run out of venous access, or they will develop some signs or symptoms of venous obstruction that creates a problem. Now again, that's my own experience with congenital heart patients, and I think all of us have a few of these patients. So out of necessity, we figured out how to recannulate some of the occluded femoral veins so that we can get to the IVC, so we can get to the heart to do our CATs for either diagnostic CATs or interventions. So we've learned to do that. Now, I've published on those in the past. However, there are also asymptomatic patients who may not have congenital heart disease, who need central access, but they also can run out of venous access. They're mostly patients with chronic diseases, and I'm focusing on these patients don't even have congenital heart disease, so we don't see them, or at least the people who are managing them don't know to call us when there's a problem. So these could be older congenital heart patients. They could be premature infants. In your NICU, there's probably 1 or 2 infants that need access that they can't get. Patients who've got short gut syndrome after NEC, they lose a lot of their intestines. They're IV dependent for TPN for the rest of their life sometimes. Cystic fibrosis patients, oncology patients. There are also symptomatic patients, such as patients who have SVC-IVC syndrome, again, from different diseases, and I'll show some of those examples for you. Thrombophilic patients who have propensity to clot off. The problem is, it's not a problem until it becomes a problem, and then it becomes a big problem. So the question we have to ask ourselves is there any way we can avoid this big problem by being proactive? So again, I've shown these pictures before. You can have obstructions in systemic veins at different levels. Here's the femorals, here's the iliacs, the distal IVC, the proximal and mid IVC. It could be combinations from the IVC to the iliacs. It could be even proximal IVC. All these can get you into problems. Some of them are symptomatic, some of them are not. Superiorly, here's a congenital heart patient, mustard. You can see the mustard baffle obstruction, totally obstructed. You see here's another obstruction in a gland, innominate vein. This is after a transvenous pacemaker. And this is a neonate who doesn't have heart disease but had a PICC line in the neck. You see that you can have all kinds of obstructions above and below, which can become a big problem over time. Here's a patient with thrombophilic syndrome, and you see how long the segment stenosis. You're beginning here. You see a little bit of thrombus sitting in the remnant iliac, and it just doesn't go anywhere all the way up to IVC. So this patient is living off collaterals. Here's a patient with Paget-Schroeder syndrome. There's a compression of the first rib and the clavicles. See how it's gone? So again, you can have these. None of these patients have congenital heart disease, and they're probably sitting in your hospital with people who their physicians are looking for help, but they don't know who to ask because they don't know that you can take care of this. Here's a nice example of a patient with factor V Leiden syndrome. All right? So this is an adolescent and a heme patient, and you see that there's just nothing anywhere. The whole IVC is gone. He's living off the paravertebrals, eventually makes its way to hemiazygous continuation. So let me just show you one case. This is a sentinel case to me because this is the first time I thought about how maybe these kinds of revascularization can help other patients besides congenital heart disease. So this patient came to me a couple years ago, 5-year-old, ex-premature infant, history of NEC, now with short gut syndrome, totally DPN dependent. She's had long history of multiple line infections, a loss of vascular access. At this point, she has one remaining line in the left IJ, and that became infected. And the story was that the physicians tried to treat her through 2 weeks of antibiotics, and she kept coming back with positive cultures. So eventually somebody said, maybe Ing can take care of this. I look at this and I said, maybe I can do something. So I brought her to the cath lab. So the first thing was, never believe when somebody tells you the veins are gone. Check for yourself. So here's the vein truly is gone, the femor's gone, the iliacs is gone. There's a little tiny beak here. This is probably where the occlusion started at some point in her previous lines. So she's 5 years old. So who knows how long this was gone for? It could be years. So very long segment, and then of course the long segment of stenosis leads to occlusions. So we finally was able to find a little wire and we can make a little contrast. You can see the contrast staining here, but as long as the contrast stays within the lumen, it's not going to spread. You're pretty comfortable that this is inside the vessel. Here's the lateral. You see the little beak here. So this is the remnant femorals. You see all the collaterals? She's just living off their venous return using these collaterals. So we find a way. Actually, every time I see a loop in the hydrophilic wires, it's actually a good thing. Don't pull it back. Keep the loop because that can push its way through. You see what I'm doing? I'm pushing, I'm rotating, and eventually it makes its way across the occluded vessel. This is the IVC. Finally, you see it pop up into the right atrium. So every time you see the curve, take advantage of it. Don't keep the tip on. So here is the remnant vessel. This whole IVC is occluded. This is probably where the renal veins come in. And so, of course, because of the high flow, the IVC remains patent. So we balloon it, and we just balloon it. And then at this point in time, we find something that it's a little bit more reasonable. But still, this is not good enough. Remember, this patient is still infected. So we decided to just put a new central line in here for antibiotics so we can take out the infected line from the IJ. So that's what we did. And I told the infectious disease people, said, when you're ready, when the patient is infection-free, call me back, and we'll try to revascularize this so that you have another vessel to use in the future. So this is the new PICC line that was used for antibiotics and for TPN, and see how long this length is. It's 157 centimeters in length from the femorals all the way up to the IVC. So 21 days later, I got a call from the ID department and said, okay, this patient infection is gone. Can you do something? So we got back in here. You see that this line actually was coming through the innominate vein. You can see how this is very tight. Imagine the surgeons doing a cut down here. There's no way they can put the line in here, even if they can get access up here. And you can imagine this is not a good pathway for any surgeon to try to put a line in, even if you can get in. So we come in from below because now we have that access from below, and we come in, you see this innominate vein that's occluded. We actually have a line from above. And you can see the simultaneous injection that there's a tiny area that is occluded or very tight, but at least it's very close to each other. And we actually run the catheter through here. We're trying to get as close to this area of obstruction as possible. And here's the angle glide wire making our way here. And at this point, it's obstructed. This is the obstruction here. But because we have two targets now, we put a snare there. We're able to find that wire through the stenosis. Now we can snare it. Now we have venous loop here. So at this point in time, I could put a new central line in that can be used for her TPN. Now keep in mind, it's much better to have a central line in the neck than the groin. So at this point in time, we just put a new line in. We said, use this new line for your access. In the meantime, we went back down to the legs. We actually did a bunch of ballooning, just open up as much as we can. Again, you see how ballooning doesn't work very well. It recoils back. So don't believe that angioplasty is good enough. So then we finally, this is the central line that the surgeons helped me do a cut down. They put it in. So now you can get the catheter and get it into the heart. So now you have a new PICC line there. So then we focus to the bottom, and we end up putting 1 stent, 2 stent, 3 stent, 4 stent, and then here's the remnant. So now we've revascularized the femoral and iliac and IVC. So now, in the future, if the patient has another line infection, at least you have a plan B. Right now you have another place you can put a line so that you can get rid of the infection. In fact, I haven't gotten the pictures. We actually went back and opened up the right IJ as well. So now she's got 3 vessels that she can use for central access. Remember, she's 5 years old. She's totally dependent on TPN. This is a lifetime dependence. So after this case, I started thinking, there must be more patients who have this problem, but their physicians don't know that this can be done. In fact, I don't think even our interventional radiologists know how to do this kind of stuff. So this is a paper that one of my colleagues, Patrick Sullivan, had pulled out. I thought this was really interesting. So the title of this is Indications for Pediatric Intestinal Transplantation, a position paper from the American Society of Transplantation. So basically, they're talking about what are the indications for intestinal transplant. We know that the morbidity, mortality of intestinal transplant is even higher than the liver and the kidney. So and the idea to take somebody to put an intestinal transplant has to be a big decision. But if you look at it, one of the indications, and let me just read this, life-threatening complications warranting consideration for intestinal transplant, including TPN-associated liver disease, that makes sense, recurrent sepsis, and threatened loss of central venous access. Imagine that. You would actually take a patient and do a transplant of the intestines because you didn't have central venous access. So if the team knew that this could be something that happened down the line, why not change that paradigm and think of fixing these veins when they are noted to be clogged? Don't give up on those. Because if you do that, you won't have to go to intestinal transplant just because of that. Remember, the longer the vessel becomes occluded, the more fibrotic it is, the harder it gets to recover. So luckily, she was only 5 years old. Second case, this is a 19-year-old who later on was found to have factor V Leiden. He plays baseball. He's right-handed. He always thought that his right leg is bigger because that was a stronger leg. Of course, the right leg is swollen, and in fact, when he runs, there's discomfort in his calves. So you can see the big difference. Well, this is his clot. This is the picture I showed you earlier. There's a long, old clot here. It's all the perivertebral collaterals, and it's making its way up slowly, slowly. The right side is actually gone as well, but at least this pathway, the collateral system is a little bit better. Now, he noticed this problem since he went into puberty. What happens is that as the body gets bigger, there's more need for blood forward and return. The collaterals can keep you asymptomatic until you outgrow those collaterals. So suddenly, during his growth spurt, he's finding this to be a venous problem. So just because the patient does not have symptoms, it does not mean that the symptoms won't come till later on. So just be aware of that. The babies can have a great propensity to develop venous collaterals and keep asymptomatic, but they will not keep up that venous collateral flow once they get bigger. So I just want to warn everyone of that. Don't just forget about it. So again, we do the same thing. We make our way up there, and in fact, we were never able to get to the heart. I'll show you what I mean. So here's a picture. This is long. You notice that the contrast does not go to the heart. It goes up. So basically, the only thing he has left is a connection to the APCIS system up the IVC. So therefore, the true IVC is already gone, and I was never able to get in. But we know that this is going to be a problem. So we actually, in fact, we end up putting a bunch of stents in to open all that up. So this is a collateral, if you will, that gets into the APCIS system so that you can improve that. We actually added a few more, so we're actually now going down to the bifurcation. So this is a bifurcation stent in the veins. And so we're creating a new iliac bifurcation, if you will. And this is what it looks like finally. So now at least notice, remember all the collateral flow before and how sluggish that was. At least now you see blood actually moves up much more quickly. So this is what he looked. This is the next day. Now this is still bigger than the right's still bigger than the left, but you can see that there is actually an improvement already. So he went to playing baseball. He came back. We saw him 2 years later, and you can see that there's a much more equalization of the legs. It's still bigger, but much less difference because the flow has improved. So we actually did a follow-up, and it's remained patent. We actually went ahead and ballooned it some more, and I think at this point in time, he's actually pretty good shape. You can never get it fixed to perfect, but at least you improve it. Third case, 19-year-old who had a lymphoma of the mediastinum and had radiation treatment. After that, he gave me a history of 2 years of never being able to sleep flat. He has to sleep sitting up because when he sleeps flat, his head feels very full. He has never been able to bend down to tie his shoelace for 2 years. So he buys the shoes that has Velcro, so he doesn't have to bend down. So I took a kid, again, I was asked to take a look at this, and you see how basically, probably because of the mediastinal radiation, there is no SVC coming through here. Same thing on this side. So you can imagine the blood from the upper body cannot get down to the SVC. It's going to make its way through the paravertebral venous system and get down to the heart in that way. So we find the remnant SVC here. It's basically gone, right? The subclavian's gone. Here's the innominate vein. It's all gone. So again, this is again from his treatment of his leukemia or lymphoma. So basically, he's living off these collaterals. See how it's making its way back to the heart through the paravertebral venous system. And at this time, I consider him to have SVC syndrome. He cannot bend down. I wish I took a picture of him because when we bend down, his ears turn bright red. Just there's no way for the blood to get out. So we first stented the SVC. So at least now you see, remember the collateral that was here? At least now you see more normal flow from the subclavians, from the IJ back down to the heart. In fact, I took these pictures in advance to show this is a very swollen mastoid here. You notice that there's veins on his chest anteriorly. The neck is swollen here. This is afterwards. Just comparing it. Again, without the comparison, you might not notice, but see how less swollen this neck is? And this is after we stuck catheters into the neck. So this is his norm. This is immediately after. And I didn't do trick photography. This is what he looks like. The veins are gone. So that means that we have better decompression of the veins from the upper body. The next day, he actually wanted to show me that he can bend down. So he couldn't do this before, but now he can bend down. He can lay flat. He can even tie his shoelaces. So at least from his symptomatic point of view, this was a huge success for him. Because who wants to sleep sitting up for the rest of your life? Now, we spent a long time with that first shot. We brought him back, and now we're going to go after innominate. Again, if you see these little beaks here, this is a good sign that you may be able to get there. So here's the beak coming from below. Here's the beak coming from above. If you see that, again, we were lucky. We were able to get a little angle glide wire. We snared this. So now we have a venous loop through that. We use a loop to balloon the whole thing, and we put the stent in. So now, APCIS, we actually recannalized and rehabilitated the innominate vein, SVC, right IJ, and subclavian. So you can see how brisk this flow is. Remember what it was like before, where all the venous collaterals had a hard time making its way back to the heart. So he did great. Okay, this is a case that actually has congenital heart disease. And I think for some of the surgeons, this would be interesting. This patient was referred to us from another hospital, had DTJ, had an arterial switch. The surgery actually was very good. Technically, everything went well, but the kid got stuck in the ICU because he had anasarca, pleural and pericardial effusions. And they noticed that the kid had SVC syndrome. And you see how we brought the kid in and we see that there's SVC's gone. Why did this happen? I don't know. Maybe there was a superior a PICC line from above. Again, this is a complication of the surgery, even though the surgery went very well, right? This is not related to the technical part of the surgical repair. It has to do with a venous problem. You hate to have a patient with this outcome, even though the surgical outcome was good. So again, we see all this venous collateral here. Where from below, you see the clotted SVC. We're able to find this little remnant beak here, and above here, again, you see that there's a long distance of clots or stenosis, and the peak is right there. Here we are. Here, let's see, go. So we find out, we're making our way a little bit at a time. Every time you move a few millimeters, you take out your wire, you take a picture. As long as you're not extravasating, you can keep going. But you can see that this is still in the blood vessel. We're making our vessel. Now, this is above the clavicle now, and you can see how every time when you move the wire, you can advance the sheath a little bit, the catheter, and you can make your way all the way up. Okay, so finally, now you notice we're way up into the neck. This is the base of the skull. Here's the clavicle here. So you see this remnant, tiny little vessel that goes into the base of the skull. But here's the big collateral here. So again, you're trying to open up this whole area. This is area that's actually all occluded that we're able to get through with the catheter. And so you're finally getting to a spot where there's actually, the vessel is actually reasonable size. So that's the other end of the occlusion. But see how long this is, from here all the way down to the SVC. I think this was probably a IJ PICC lines. Again, we went up and ballooned the whole thing. This is what it looks like after. Again, there's still collateral, but a lot better than what we had before. See how some clots here? So we actually went in and did some thrombectomy, mechanical thrombectomies here, and removed some of that. In fact, you can see some thrombus here that we were able to find afterwards. And we sucked out some of the blood instead of some old clot, some new clot, and we were able to get rid of that. And then now we're going after now. So we clear this, although we know that we need to do something besides that. So we have a wire here. Now we're aiming for the innominate vein. And the same thing. Now you run past here. You can get back to the other side. The whole innominate vein was also occluded, right? This kid has just tremendous SVC syndrome. And again, we ballooned the whole innominate up into the left IJ, and this is the result of that. Here's the area where the original problem was. It's an old clot here. Probably blood could not get down here. The thrombus propagates up the IJ on this side. But we're able to get back to this point. We know that we have to do something significant here. So we put a stent in. So now you see how the flow goes up, but see how much more easily is the blood coming back to the head. And remember the old venous collaterals? They're not there anymore. They're gone. It's not that they're gone. The blood doesn't have to go there. So this is before. I just happened to do this just to prove to myself. So you get all this pitting edema. So you push your finger on the third. You see this pitting edema before we cath. One day after, and again, this is not trick photography. This doesn't look as pitting as before. 3 days after cath, you don't even see it anymore. And you see the head is no longer this swollen. It's still swollen here, but see how much more normal that is. That's 3 days later. This is before, this is after. See, the head is much more normal looking. Here you have all this, and I don't know why the belly also improved without any new treatment, but once we open up the SVC, all the anasarca, all the edema and the tissues have helped improve. 3 months later, we brought him back in, and then we actually thought we better fix the innominate vein as well. So we ended up stenting that as well, and we made the SVC bigger. In fact, we end up, see this, sometimes you get these little stenosis here. We end up putting a stent through that as well as we open that up. So now you see how the innominate vein, the SVC, the right-sided IJ, everything looks wide open at this point. And this is 3 years later of the same patient. And you can see how it's a lot nicer. I forgot to loop this. So we actually made it bigger just for good luck. And this is the final shot of that. You see how it's actually, the collaterals that we saw here, totally gone. Over here, totally gone. And yes, you can say this a little narrowed here, maybe a few collaterals, a lot better than it was before. And this is what she looked like 9 months after the procedure, 1 year, 2 year, 3 year. Her head is completely normal at this point. So I think this was a good save for the patient. Again, I want to emphasize that the cardiac surgery was perfect. Nothing wrong with it. It's the neck vessels that was the problem. So let me summarize how to change this paradigm. First of all, occluded systemic veins can occur outside of congenital heart disease patients. So there's a huge patients loop out there. Occluded veins can, even chronic ones, can be recannalized and stented safely and effectively. Stented veins can be life-saving for those who are central line dependent, especially TPN for short gut syndrome. The signs and symptoms of venous insufficiency can be relieved once you do this. So the paradigm shift is don't give up on an occluded systemic veins. I would encourage that some of the young interventionist here. Now, you know that you will never get to the level of your mentor, teacher at this point because they're so good at what they do. So what you have to do is to find an even playing field. So if your senior attendings don't want to deal with this, you do this because then you become the expert. So this is a challenge to the younger attendings because there are many patients in your hospital that from other divisions that can use this, but they don't know that you can do this. So this is a way to expand your practice if you want. Thank you. Sorry for taking more time.